Welcome, everybody, and good afternoon. My name is Laura Sparkman. I am the Vice President for Clinical Effectiveness for Advanced Practice Strategies. Welcome to our conference call this afternoon. We have a very special guest we're very excited about. I'm going to lead the conference call off with just a little bit about what GNOSIS for Obstetrics is, and then we're very excited. We're going to hand it off to Lorraine Parker, who is the patient care administrator for Winnie Palmer for moms and babies. She's going to be talking about a blended model of education, and really it's kind of very exciting because Lorraine just had the opportunity to showcase this program at the Institute for Healthcare Improvement National Conference that they hold every year. So congratulations to that. I'm going to do a quick introduction. Lorraine Parker has been an RN for 24 years at Arnold Palmer Medical Center, primarily in obstetrics and critical care OB. She obtained her bachelor's in nursing from the University of Central Florida and her master's in nursing leadership from Chamberlain College of Nursing. She attended a national certification program as a certified nurse manager and leader. Lorraine has held several different leadership positions in women's health, including nursing manager for a labor and delivery unit, and specifically Winnie Palmer, which delivers over 14,000 babies annually. Her current position, as I said, is patient care administrator for obstetric services, and she is responsible for Winnie Palmer Hospital for women's and babies. Welcome, Lorraine. We're very excited to have you.
Thank you.
We're going to go through a little bit of overview of APS and GNOSIS for OB. Lorraine will go through her presentation, and then we'll have some Q&A at the end. So just a quick minute about APS. We really have two primary solutions. One is called Prophecy, one is called GNOSIS. You're going to hear GNOSIS for OB. Prophecy really is an onboarding solutions and nurse retention program. It's evidence-based. It's a fantastic program. If you're interested in hearing more, just please contact us at the end of this conference, and you'll also be receiving just kind of a follow-up courtesy call from our team as well. And then education and patient safety risk mitigation solutions around obstetrics and emergency medicine. So GNOSIS is, many of you may have already heard and know a little bit about it, but we are an assessment-driven education and analytics platform. It's really changing the way how physicians and nurses are learning because of that. It's assessment-based. You'll see here in this first box, number one, we measure two primary variables: knowledge and judgment through a validated assessment. Physicians, nurses, residents, midwives all take an assessment that is germane to their scope of practice, and that will, out of that, derives an individualized learning path, is what you see here in the second box. Our platform is web-based, which is why you see these pictures of iPads. So it's serviced as a software. Anywhere you can access the web, you can access our learning solutions. It's a very simple, no IT involved, really, a username and ID, just like you would access Amazon.com as an example. So you get a personalized learning path prioritized in red, yellows, and greens, red being content that you need most, and it's prioritized, all the way to green, which is content you actually can test out of, which means that your learning path is variable among the team. The team, each individual gets what they need. So the concept is you can test into content and you're testing out of content. Very satisfactory and satisfying to the care team. And then because it's assessment-based, it drives analytics. And we designed the content in primary categories that we call practice areas. And these are really important clinical content pieces every clinician needs to have in order to be proficient in their in the 4 high-risk areas of OB. And what I'm showing here are the 4 primary programs that we have. We are launching a new program in 2017 focused on reducing low-risk primary C-sections. We know that's a hot topic as well, and that'll be available mid-third quarter 2017. Our largest assessment-based courses are fetal assessment and monitoring, hypertensive disorders in pregnancy, obstetric hemorrhage, and shoulder dystocia. Each one of those has a separate and unique individual assessment, and then out of that, you are, as an individual clinician, given an individualized learning path based on that content. And then what you see there listed below, the 10 items called clinical pearls, are 30-minute case-based supplemental learning modules. So, for example, if you score poorly in the NICHD national standards in the common language, you might launch clinical pearl number 5, and it's a focused additional supplemental learning element on that language. And again, we can spend more time with you if you have interest to learn more about how this program works. But this content represents the highest risk areas in obstetrics. I do want to show everybody these are the 4 primary courses and the clinical pearls that you heard me talk about. And then I was transitioning to talk about a joint partnership and work that we're doing with AWHONN around improving outcomes for mothers and babies. It's a very unique program. AWHONN has validated all of the GNOSIS content, and we have an advisory council that represents over 400,000 live births that is going to be supporting organizations that join Mothers and Babies First in improvement in all of these areas in that orange box, reducing delays, responding to category 2 and 3 tracings, improving outcomes in obstetric hemorrhage, reducing brachial plexus injuries, and so on. We're happy to talk to you more about that. The goal is we're going to be at the June 2017 AWHONN convention with Lynn Erdman, President and CEO of AWHONN, talking about early results and correlating GNOSIS scores to your clinical outcomes in these areas. And I do want to say Lorraine Parker is an advisory member to Mothers and Babies supporting AWHONN and this project. So we're very excited about that. So Lorraine, I'm going to hand it off to you, and if there's a delay in the slides, just let me know. So I'll go ahead and go to your first slide.
Okay, that sounds great. Well, thank you for giving me the chance to come and tell you our story here at Winnie Palmer. I'm really proud of our team here and all the hard work they put into the project that we did. So basically, I'm just going to be talking to you today about what we did with our project with team training, how we kind of developed the team training program, how we implemented it, and then how we plan to sustain it. So to give you just a little overview of Winnie Palmer Hospital, we are one of the biggest birth centers in the country. We're the second busiest birth volume hospital with over 14,000 births. We have 27-bed labor and delivery room, which needs to be bigger. We have 5 C-sections, the ORs, that are dedicated just to C-sections. We have a 25-bed women's triage unit, which is the busiest L&D triage in the country. We have 102 postpartum beds. Soon to be more. In January, we'll be opening another 34-bed postpartum unit and taking that number up. We do many minimally invasive surgeries here. We have a robotics program, and we also have our GYN and a GYN oncology program. What I'm here to talk to you today a little bit about is our joint venture that we embarked on with the AHRQ, or the Agency for Healthcare Research and Quality, and Duke University. They had reached out to us and said they were looking for a very busy birth volume hospital to be part of a cohort of 32 hospitals, that they were really going to go in and look and see if by doing some standardized education and standardized processes in conjunction with Team Steps training, which is a product that's been used for many, many years in the airline industries and has made its way into healthcare but hasn't had as great a success as they would have hoped. But they were hoping if they could put it into obstetrics, could it make a change in outcomes? Next slide. And so basically what the project was not only to train your team in Team Steps, which for those of you that aren't familiar with Team Steps, it's really a product that focuses on communication, standardization, and really gives you tools to teach your team and how we can all kind of speak the same language and kind of play from the same playbook so we all know and use the same language, and I'll go into that a little bit more. But what they really wanted to do in labor and delivery was focus there, because we have events in OB that don't happen that often. They're very low occurrence events, but the outcome, the significance of bad outcomes is high. So when you have something that doesn't happen often and bad things can happen, there really is an opportunity to try to streamline those processes. So they wanted us to train the team and really focus in on two things. And they gave us a whole list of things that we could pick from. And of course, we picked one of the hardest two, which was electronic fetal monitoring, specifically Category 2 tracings, and OB emergency teams. And we specifically picked Category 2 tracings because we internally were having a problem with communication in relation to these strips. And I won't tell you we've conquered that. That's still, I think, a challenge for everybody right now, is that gray zone with Category 2 tracings. But we really felt that we could at least put some tools in place to make it a little bit easier on the team. Management of Category 2 tracings was picked, like I said, because we were still having a challenge. And we found that anytime we had root cause analysis here, the key issue was that the provider just didn't have the same understanding necessarily that the nurse did. And, you know, one of the examples for us that really kind of was the catalyst to us really joining this joint venture with them was we had a provider who was downstairs having coffee, and I guarantee you in all of your institutions you have a story like this. And he got a call from the nurse who said, "Hey, I really need you to come up and look at this tracing." And what he heard was, you know, "I need you to come up and look at this tracing," with no sense of urgency. So he stayed down in the doctor's lounge, had finished his conversation, finished his coffee, comes up to the unit, and the next thing you know, we have a stat C-section with APGARs that were not what we would have wanted. And when we did that root cause, luckily, you know, the mom and baby did ultimately do well. But when we went in and we looked at the root cause, it was the disconnect between what the nurse thought she said and what the physician heard. And that's what really said, you know what, we really have a problem here. So when we joined this program, what we had to do first was, you know, we wanted it to be, they wanted measurable outcomes, not just did we think we made a difference, but could we prove it. So we submitted data that we already currently submit to the National Perinatal Information Center, NIPIC, which really tracked our hospital volumes and what type of, you know, center we are. We submitted our outcomes data for our C-section rates, our birth trauma rates, and then they also went into our risk and claims data to really look at what kind of outcomes we were having. And then we had to submit our 2014 AHRQ survey, which is the survey related to the staff's perception of safety on your unit. And they really focused in on the questions that were related to teamwork and communication. And that was basically going to be our, that was basically going to be our baseline as to how we were going to do the project. And so the project was going to last 18 months, and then in February of 2016, we started in late 2014, completed the project in January of 2016, and the focus was really on those teamwork and communication questions. And then at the end of the project, we would collect post-implementation and outcomes data and resurvey the team using that survey. We went, and there was myself and our project director went up to Duke University, and we spent 2 days getting trained on being a master trainer in team steps. And really, the different approach than I think had been done before was they trained us to be a team trainer and then said, now we want you to go back to your institution and implement it in a way that you think will work for your team. And so they really didn't tell us how to do it. They kind of left that to us. So the first thing we did is we said, well, what is a high-performing team? And, you know, we really came back feeling like we have great outcomes here at Winnie Palmer. We deal with a lot of volume. We see a lot of very sick patients, deal with a lot of high acuity. But when we started really looking, we realized we had a lot more opportunity than we realized. And so we first looked at what kind of team did we want. And, you know, with team steps, the top 3 in red are the big things that you're looking for. You want to make sure that everybody in that room caring for that patient has the same mental model. You know, we all have the goals of having a healthy mom and a healthy baby, but that's really sometimes there's other smaller goals that maybe you're working towards that you need to make sure you all are working towards that same goal. Make sure that everybody has clear roles and responsibilities, that everybody knows what their role on the team is, that we have a clear, valued, and shared vision, that we optimize resources, and not necessarily within the big team. What we learned is you have to look at a small team, and you might have a team in a room that might be a physician, a nurse, and a patient that come together for 12 or 18 or 24 hours, and does that nurse optimize all the resources available to her that day on the unit? Have strong team leadership. Who on that team? Is it the nurse? Is it the physician? Is it the patient? Who's in charge of the situation that you're dealing with? Making sure that you engage in regular disciplines of feedback, develop a strong sense of collective trust and confidence, and making sure that you have the mechanisms to fix those when things go wrong, and so that you can have the best outcomes that you can get from the big team, which would be your labor and delivery team, and also that small team, which is the team within that patient care group. We decided to get some of our brightest minds together. We went and gathered up some of our physicians and our nurse leaders and actual staff nurses from our unit practice councils, and we got them all together in a classroom and said, okay, let's go through and figure out where are we as a team. And we realized that we had some areas that we had high-performing teams, but we also had some areas of opportunity. And we're a teaching hospital here at Winnie Palmer, so we have residents coming through all the time that are 1 month or 2 months or 3 months into their OB rotation. And so they do that changes your team dynamics every year when you change up a new group of residents. We also decided that we needed a baseline to see where we are from an education standpoint. We realized we had a lot of nurses that came to us from different hospitals and different backgrounds and brought with them all that knowledge. We had nurses that were brand new out of graduating out of nursing school, and we also had physicians from all different parts of the country. So we decided we wanted a baseline of what knowledge was already on our team. So we had all of our providers, and with our providers, we have our physicians, all of our almost 150 private physicians that practice here, as well as 40-plus employed physicians. So we linked it to recredentialing. That over the course of the 18 months that they were in their recredentialing cycle, it was required that before they could be recredentialed, they had to take pre-assigned modules, and we started that journey 4 years ago. So they started with fetal monitoring, and then when we were doing this project, it was postpartum hemorrhage and shoulder dystocia was added to the fetal monitoring that they had already done. And then we had all of our nurses on all of the different OB units take them as well. And then we used that to try to guide where we wanted to focus our education for this project on. And I think this score is actually just for the nurse midwives, the providers, and the physicians. And I think this is what helped drive our point home for them, because they really thought, hey, we do this all the time. In postpartum hemorrhage, we had done a project with the Florida Perinatal Quality Collaborative that was focused on standardization of postpartum hemorrhage, and we had already completed that. And our postpartum hemorrhage rate is very low, and we're one of the best in the state, so we felt we were really good. But when they got their scores back, and if you really want to be in that top right-hand box with high judgment and high knowledge, and when they saw they fell below the norm for their knowledge, that kind of surprised them a little bit. They did all right in their judgment, but there were still people better. But their knowledge scores were not where we really felt they should be, nor did they. And that really, when we presented this slide at the department meeting, I think was kind of a surprise to them. And of course, they questioned the data, and we had to go through and look at all the individual scores. And I think there was a surprise. And then when we broke it down even further, the physicians actually scored lower than some of the midwives. And it wasn't that they weren't wonderful physicians. It's just some of them had been out of school for a very long time, and they were maybe not up to speed with some of the newest and latest and greatest literature on postpartum hemorrhage. So this was a really big deal to them, and really engaged our physicians in wanting to be part of this project. So basically, team steps in this project was about building a comprehensive unit-based safety program, and you've probably heard it called CUSP. And it's really based on the fact that culture is specific to your unit. If you want to change culture, you can't go into a hospital and change the whole hospital's culture. You have to do it part by part, piece by piece. And you have to tailor it to fit each individual unit. And so, we picked labor and delivery. We decided we weren't going to worry about triage and the OR and the mother-baby units. We were just going to focus on labor and delivery and the labor and delivery OR. And so that's kind of where we decided was the culture we would try to work on first. Because what we did in labor and delivery, as we now work on spreading it to the NICU and to the mother-baby units, the project has to be changed to fit those units. The things that were important to the labor and delivery team may not be the same cultural problems that they're having on other units. And so the initiatives that you pick, your quality improvement projects that you pick, have to be things that matter to that team. Because if it doesn't matter to them, they're not going to buy into it. You have to make sure you include everybody on the team. It was important that even the environmental services workers that were cleaning the rooms understood that when we were asking for things and using these new communication tools, that they had the understanding of what was important and what was urgent. And it really encouraged a shared mental model, so that if your housekeepers and your transporters and everybody besides the nurses and physicians know that when these things are being said or these things are happening, it's a significant event, it really helps everybody kind of jump into action for the same reasons. So then we came to implementation. So we knew that we had some gaps in our team as far as not being as high performing as we wanted. We knew we had some gaps in our education, that some of our physicians and nurses didn't score as high on the knowledge side of things for fetal monitoring and postpartum hemorrhage that we wanted. And so now we had to figure out how are we going to gear this training to those problems. And so we developed 2-hour workshops. We pretty much picked what we were going to really focus in on based on the scores that we got back from the postpartum hemorrhage and the fetal monitor modules, as to where, because when you talk about fetal monitoring, that's a huge it's a huge bucket of education. But what we found is it wasn't category 3 tracings or 1 that we had to worry about. We really focused in on those areas with category 2 tracings that we saw on the testing had some opportunity, and we looked at postpartum hemorrhage, and what we found was we were doing a lot of great work, but our physicians didn't even really know why. For example, one of the docs, after he took the module, said, wow, I always wondered why the nurses were weighing those sponges, that we'd been doing it and he'd seen it, but he really didn't understand why we were doing it. And so taking the training really helped him to kind of connect all those dots. So we developed 2-hour workshops that were really focused on standard work, making sure that we were all doing the same thing, and really focused in on some key communication tools for our nurses. We set up simulation drills. We got some physicians that were willing to be part of it, and after the 2-hour workshop, then over the course of the next 6 months, they had to attend simulation drills on SBAR for fetal monitoring and postpartum hemorrhage drills. SBAR was a big thing. We really focused on making sure that as they communicated that they felt comfortable with that tool. And then we implemented safety huddles at the start of every shift, and that's probably one of the best things that we did. Basically, every morning at 6:45, every nurse that's coming on shift, or at 6:45 p.m. that's coming on for the night shift, have to stop at the huddle. And it's 5 minutes, and we've timed it for the first few weeks that we did it to make sure it was no more than 5 minutes. And the off-going shift charge nurse, and we have 2 pods of labor rooms, and we have a separate OR. So we have 2 charge nurses in the labor room, a charge nurse in the OR, and a charge nurse in the ICU. And they each come and report off on their area. And they run through basically just, what they have to pick 2 patients that they're the most concerned about. So they might run through that we have a lady on, the B pod that had a postpartum hemorrhage last night. We're going to keep her for an extra hour. We have a category 2 tracing in, the A pod that anesthesia is aware we may end up going to the OR. And we kind of put everybody that's on any part of the 2nd floor. So you may be hearing about patients in the OR that you might be in a different area, but everybody on that whole floor is aware of the patients of concern. So that if an emergency light goes off, they're all aware. Anesthesia attends the huddles, the anesthesia doc. We list who's on for all groups, so they know if we have some very big, large groups that have large patient volumes. They know which physician's on call each day. They know if there's any safety issues as far as, we've got construction going on. So if there's an elevator down, they know at the beginning of the shift, not to use those elevators. They know if there's any staffing issues from, if anesthesia has some staffing challenges, they make that aware. If we have nursing challenges, that's put out there. And then our neo providers come. So we have an ARNP from the NICU that comes down that can listen if we have any, 24-weekers on the board. They're aware of what patients they might want to go and see. And we do that every day. And that actually was a culture change that's now so embedded in our culture 2 years out, that if we happen to be running late to one, we will get calls from the physicians wanting to know what's going on with the safety huddle. Briefs throughout the day. If there's a patient of concern, we'll get the group together and say, hey, what are we doing with this patient? And it's the physician provider, the nurse, and the charge nurse, and sometimes anesthesia, to make sure that we're all still on the same page with the plan of care. And then we do debriefs after any, hypertensive crisis, postpartum hemorrhage, shoulder dystocia. We have a little 5-minute debrief to say, what went well and what could we do better. So for labor and delivery, we decided that we would start with our clinical assistant nurse managers, charge nurses. We wanted to make sure that they were all bought into the idea of team steps and standard work. And so we also knew that they were going to have to be able to relieve the staff, because we were on a timeline with Duke and AHRQ. And, you know, with over 200 nurses to train, we knew we were going to have the assistant nurse managers and the charge nurses be able to relieve them. And we did have to pay some overtime for this, because we did this not very smart on us. The timeline just happened to fall right in the middle of the summer, July, August, and September, which all of us OB folks know that is when all the babies want to be born. So we did it right in the middle of our peak volume, and so that was a little challenging itself. But we were so committed to this, we said we will pay you to come in on your time off. It's just 2 hours. Just come in and give us 2 hours. Then we trained all of the labor and delivery RNs and LPNs. Our anesthesia physicians were fantastic. They committed to sending 100% of the CRNAs as their student nurse anesthetists, and then as many of the providers that were able to attend did. We trained all of our residents, all 4 years, all 7 each year, all of them attended. We got all of our OB hospitalists came. We had a challenge with our private physicians. 2 hours out of their schedules is not realistic for them. So we did do a abbreviated 30-minute video that we put on our physician portal that they could watch from home or they could watch from their office. And then we really tried to grab as many of them as we could when they were in the hospital to attend a simulation drill. And these, I've already talked about this with you, but these were the 2 things we really focused on with the communication failures we were having. And really what we found as we did our 2-hour workshops and did have some feedback is it was really the fear of conflict. The nurse was really afraid to call and say, hey, I really think that we've been in category 2 now for an hour, and I think you need to come in and we need to make a plan, and having the physician disagree with her. There was a lot of fear in that. And then with the OB emergency teams, and we specifically focused on postpartum hemorrhage, there was just a lot of confusion on who was in charge when you were in the middle of that. Was it the doctor? Was it anesthesia? And so we really felt we had an opportunity to decrease confusion in those emergencies. Next slide. So everyone participated in the APS module learning. They could not go to the 2-hour class until they had completed their modules. Now, these modules are not a one-time sit down and do. It did take a little bit of time. So they did have to sometimes, go in for a day here, and then they'd, get their learning path and go back and finish it. So we did give them 30 days to complete their modules, and then they had to sign up for a class. We had the classes lasted for 60 days. We had time frames in the morning, at night, on the weekends, and they only had to come in for 1 2-hour class, and we would sometimes have 12-hour days where we would have classes every 2 hours and into the evening. Over the course of the 30, so it was 90 days total, 30 days to do their modules and 60 days to get to a 2-hour class. We trained 250 nurses and physicians, participated in the education modules and in the 2-hour class and the postpartum hemorrhage. And then a total of over 200 participants actually went to a second simulation training, because you had to attend one. So we did the first ones on fetal monitoring, and they had so much fun with it, because what we found was then the resident would come in and say, well, I want to be the nurse, because I want to give you an example of the worst time, for phone call I ever got from a nurse. Well, then of course the nurses would say, well, then let me be the doctor, and I'm going to be the one to tell you the worst phone call I ever had to be yelled at by a physician or whatever. And so it kind of became fun, and I think the word got out. So when we did our second go around, we actually got 200 people to come to the postpartum hemorrhage module, nurses and physicians. And these are the different simulations that we have since done. We focused on fetal monitoring and postpartum hemorrhage, but as we wrapped up the program, it was so successful, we now do simulation a minimum of once a month. And these are little 5-minute simulation drills. These are not 30, 40 minutes. We do them in an empty room. We don't have a simulator. We have a simulator down at our learning labs, but we don't need that for this, because our focus is really on standard work and communication. And so if we have a rare day where we have some downtime, we'll just go in a room and we'll have one of our educators run a simulation on shoulder dystocia. And we're looking at, not only are they going down the standard work for what you need to do in a shoulder dystocia, but how are they communicating that to the physician? Because part of the drill is, okay, the providers, shoulder dystocia, the provider's there, but you now need to call for a second provider. What methods are you using? Are you using the communication tools we give you to make sure that there's a sense of urgency? So year to date, we have trained 250 team members, and what we really focused on is giving them the tools. And this is really not as much about team steps, but what we really learned in team steps is there's a tool called CUS, and C stands for concerned, U stands for uncomfortable, and S stands for safety. And so we told our team that, and physicians and nurses alike, that in all of these drills, those are 3 words that are timeout. If a physician hears a nurse say, I'm concerned about this tracing, that's a different phone call than I want you to come look at the strip, and the physician felt like he could go and have his coffee. But I'm concerned, that means that's a buzzword for timeout. And so that became kind of what we started doing as far as I'm concerned, I'm uncomfortable, this is unsafe. That really became 3 words that mean stop. You cannot, can't go any further. And it really took some of our new nurses, and it empowered them. Instead of having to, say, I don't like this strip. Well, what don't you like about it? I'm concerned. That really gave them the understanding they needed to kind of tune in. So we put 250 team members through the program. 105 went through the hemorrhage training. Another 100 went through Category 2 tracings in the initial go-round, and then we had 200 more. We had the development of the multidisciplinary safety huddles, and then we resurveyed the team about their perception of safety on the unit after the team steps training and simulation training in February. And this is where we realized that really communication is key, because if you look at these scores, so if you look at the green line, that's the national average. If you look at the blue line, if you look at the side to the left, that is our scores before we did team steps training, the education modules, and the simulation training. And we were below the national average on every single one of those in 2014. And then if you look at where we scored after this project, we exceeded the benchmark in every single one of these categories. And the one we were the most proud of, and we really feel was the key to this project, was teamwork within units. We went from the 75th percentile to the 90th. And we heard back loud and clear from our team, it's much easier when the physician, those 3 words that I can call the physician, and when the physician has had the same training as me, when I'm in a postpartum hemorrhage, now they know why I'm weighing these lap sponges, and they know why it's significant that I measure my rinse water, or whatever it is that you're working on. It really just made them all feel like they were communicating better, and actually relationships between the residents and the nursing team improved. And we have many of the residents now that are participating as we roll into new projects. We're in the middle of doing a statewide collaborative on hypertension and hypertensive crisis, and this, we now have doctors that are willing to be part of the actual groups that roll it out. And what the other interesting thing is, we saw a score that significantly dropped in the middle of this, and it was teamwork between units, and that kind of bothered us. We thought, well, what happened? But what we realized is the team in labor and delivery had gotten so used to having this now 2-way communication and kind of a shared mental model on how they talk to each other, that then when they would call the NICU or they would call postpartum unit and they weren't getting that same 2-way communication back, they were even more frustrated. So that's now our project that we're in the middle of now, is spread and pushing this team training and team learning and standardized education out to the NICU as well as to the mother-baby unit. And so then the next thing they did was they looked at our outcomes data, which that takes a little bit longer, so we didn't get that back right away. But they then looked and said, okay, so now that you've started communicating and changing the way you do things, you've had a whole educational opportunity with your providers, how did that impact your outcomes? Well, Winnie Palmer experienced a 7% decrease in our modified adverse outcomes index, which what that is basically, your risk managers would all know what that means, but it's 9 components, everything from neonatal outcomes to C-section rates that they look at, that really kind of gives you a score for risk for your hospital. And so the one that really helped to drive that down was the index of unanticipated operative procedure measure decreased by 51%. And we really feel like what that means is we stopped a lot of those trips to the OR postpartum hemorrhage that we didn't identify early enough, or we didn't get the provider here early enough, that then continues down a cascade that you end up in the OR. And we also feel like stat C-sections decreased because we got the providers engaged earlier in those Category 2 tracings, so they weren't, at that last minute it becomes stat. We actually were able to have some more controlled, because our C-section rate, our primary C-section rate has decreased over the course of this event, but not enough by 51%. So we really felt it was just taking the stat part away from it. The AHRQ patient safety indicator 18, obstetric trauma, vaginal delivery with instrument, decreased by 32%. Same thing, I think we've made things a little bit more controlled. And then Winnie Palmer is being featured in the AHRQ publication and as a case study on their website. And the surveyors actually came to the hospital at the completion and when they got our results back to see, you know, that it's great that you see these results, but they actually wanted to come in and talk to our team. And they spent a day here, met with our providers, met with our nurses, and really went and said, you know, how did you feel about this project? Did we do what we say we did? And they're publishing all of their findings and putting us as a case study. And their comment was, if you can roll out a program like this and have these results in 18 months with 14,000 deliveries, this can be done anywhere. And so that will be on there as a toolbox. So if any other hospital decides to replicate this project, they'll be able to go on there and kind of look and see how we did it in a much more detail than this webinar can provide. And now we're in the hard part, the project itself, and you know, all of that. It was hard, but I think sustaining it. You know, we've got these great scores, but we take this AHRQ survey every year. So when we come up upon this year, I think the goal for us is to sustain these results. And you know, we want to make sure it's not another thing we hear all the time. I'm sure many of you do too. Okay, great, we're going to do this new project, and then it's going to be you know, go by the wayside. It's a flavor of the month. We want to make sure that that's not the case with this. We are providing, every nurse has to take GNOSIS every year. They don't have to, their learning paths are different. You know, if they've done it before, they're really just going in and, you know, kind of updating it. We don't require all the modules, but right now we're working on hypertension, so that's the module they'll be taking this year. Anybody that we feel is struggling on the unit, we'll put them back through GNOSIS for fetal monitoring. All providers for their recredentialing every 18 months have to do a module. We did operative vaginal delivery and postpartum hemorrhage last year. This year we'll be doing hypertension and yet to be decided what else. Any new physician coming on does have to take the fetal monitoring, anything they've missed. So because we've done it for 3 credentialing cycles, as a new physicians come on, they're assigned the modules. It's not required to start, but it's required in their first 90 days. We share the data with the team. You know, when we get good data or bad data, we put it up. We want what we learn from our mistakes. We also do recognition. If we see somebody doing what we call a team steps moment, we hear communication that was stellar, or we see a debriefing after a postpartum hemorrhage that was run really well, we call it out. We have our Team Steps Tuesdays newsletters. We refresh them on the different tools that are available to them. And it's part of our daily activities. We actually use these huddles. Our safety huddles are mandatory every morning, and we learn from them every day. We actually were featured on IHI was in town here in Orlando, and they actually came and did a site visit here, and were able to do an excursion to watch our safety huddles and then go to one of our education boards up in our antepartum unit. So that was a proud moment for the team. And then we make sure we debrief after any event, and we encourage our physicians, even if they're unable to stay, because debriefing is, I will tell you, if you go, anybody that's working on any of these collaboratives or postpartum hemorrhage and different things, the debriefing is the most challenging part, and I wish I could tell you we've mastered it, but we haven't. The challenge we have is the physicians are busy. They have a postpartum hemorrhage and they're in the OR for an extended period of time. They got to get back to the office, and so we're working through a process of having them even call in, setting up a pre-scheduled time. So that one is still our biggest challenge, but we're not ready to give it up yet. So we have great luck with our residents. It's just now how do we get our physician community partners involved, and then simulate. We do simulation drills as often as possible, and we put that communication as the main focus. Even though we're looking at the clinical components, if you're doing all the components right, but you're not communicating correctly with the people in the room to know that you're doing those things, that's half the battle. So we really focus on communication simulation drills monthly. And I believe that's it. So I'll open it up at this point. Laura, if you want to take over for any questions.
Sure. Thank you. That was amazing. What a great program. You did a fantastic job of kind of going through all the parts and pieces. I would echo, I actually had a note written down to ask you, but AHRQ already took my line, which is, as big as an organization as you are, 14,000 babies, all those physicians, all those nurses, midwives, residents, if Winnie Palmer can do this level of work, any organization, can do this work. So we want to congratulate you for all your success and improvement and being transparent and sharing it with everybody. It's just phenomenal. So thanks for that, Lorraine. Just a couple of things. I think one of the evolution of education is really what you've been talking about, which is it's a blended model of education. You're coming at it from multiple different angles. You're doing online e-learning education, you're doing simulation, you're doing team steps, you're using data to drive improvement. Is that something that you really just started doing over the last couple of years, or you really just started measuring the impact of that?
I think a little bit of both. I will tell you that, in years past, we thought that classroom learning was the only way to go, and we would pull people out of staffing to go over to our learning lab and sit at a computer. And I will tell you, our volumes became our barrier. We just could not free the staff up, and we kind of came to a point in time, probably about 7 years ago, where we realized it had been a very long time before many of our nurses had even been through any kind of fetal monitor training, because the people that you keep behind are your most seasoned nurses, because you're like, okay, they know it, I'm going to send the new nurses. And we realized that wasn't working for us. And so that's when we kind of realized we needed the blended model. There are some older nurses that struggle with online learning, so we want to have the options for them. But there's a lot of nurses that would much rather sit at the computer for a couple of hours at a time and work on it. And so we want to have a mix of all of the above, but then also you need to take what they're doing on those online modules and apply it, and that's where the simulation comes in. The data part was the new part. We had never really taken to say, is this working? And that was, I think, forced by joining a lot of these statewide collaboratives and by Duke saying, hey, we want to get some research here. And we were hesitant at first, thinking, I don't know if we can do this, but we were very glad we did, because I think we didn't even realize how successful that model was for us until we entered this project.
That's great. One other quick question, because I get this all the time. We hear from our clients that are using GNOSIS and the blended model of education with AWHONN as well. But how do you get your physician engagement? Can you talk a little bit about your physician leadership, your attendings? I know you already said that you did have a little bit of challenge in getting them to participate just in your simulation, but can you talk about, their participation in the e-learning and some of the other programs, and how did you make that happen?
I'm going to tell you, I didn't make that happen. Our physician leaders did. We were blessed enough to have leaders that were very strongly supportive of the fact that we all need to be learning the same way. And we had, especially when some of the NICHD guidelines changed several, I don't know how many years ago it's been now, but many of the physicians were charting differently, completely different context than what the nurses were charting. And so we had some physician leaders who said, if the nurses are going to have to do this, so are the physicians. And they took it to the higher physician, organization-wide physician leadership group, and said, this needs to be tied to recredentialing. And if you want to work at Winnie Palmer, then we want the best of the best, and this is our requirements. And so that was where the change happened for us. Prior to that, we had a certain group of docs that would always, be on board. But when it became part of recredentialing, that's when everybody really kind of, I hate to say had no choice to get on board, but that's kind of what happened. Participation in everything else, it's funny. Some of it's peer pressure. The first couple of docs did it, and we made a big point of recognizing them, and some of the other docs got on. We still have holdouts, and it is, that part is, I wish I could say it's 100%, it's not, but I think you have to start somewhere, and I think physician leadership is the key. You have to have physician leaders that will buy in and support it, and sometimes a couple of bad things have to happen to get that to happen, sadly, but or you can point out where bad things happen somewhere else and we don't want to be there, which is what we did, and I think that's the key. So you got to have physician leadership.
Excellent, excellent. Tom, any questions that came in through the participants?
Hi, Laura. Yeah, a few did come through. Lorraine, someone wants to know, and you may have answered this, what time are you doing your safety huddles, and who all attends, and at the shift change or just once per day?
Both shift change. So we change shifts to 7 a.m., 7 p.m. We do them at 6:45. We have the nurses' lounge. They come out of the locker room kind of right into this big lounge, so they have to stop there. And I'll tell you the other side benefit is you kind of start knowing who's not getting to work on time, because we do it right there, and then the assistant nurse manager from the previous shift is there. They start at 6:45, they end at 6:50, and we had to have a stopwatch initially, because we wanted to commit to them that we would not hold shift change up. So they come in at 6:45, and it's attended by all the oncoming staff. That includes nursing assistants, scrub techs, anybody that, environmental services, anybody that works on the second floor. So that includes our ICU team, both of our labor and delivery pods, our pre-op, PACU, and OR staff. We have a advanced practice nurse from the NICU that comes down every morning and evening, and then we have our anesthesiologist that's on for the day, or a CRNA, whoever's not in the OR that attends, and then the off-going assistant nurse manager or charge nurse from each area that attends. And then we do that both shifts. So it's kind of the expectation you come straight to set, clock in and be there at 6:45.
Great. Laura, these are some questions that you can answer quickly. Can clinicians earn CME and CE credit with GNOSIS?
Yeah, great. In GNOSIS, you can earn CME, CE in 15-minute increments. So the way it works, remember, is you're doing your assessment first, and then you're doing your learning path that follows as soon as you complete your assessment. But you're even earning CME while you're in your assessment, because we know adult learning science says that even while you're being assessed or tested, you're learning. So we give you credit for that. Our courses are accredited every 2 years, so therefore they have to be updated and reviewed every 2 years. And Lorraine, I know you know this. I wanted to share this with you. I know you were talking about Category 2 tracing, but in the new in the recently released fetal assessment monitoring modules version 2, the Stephen Clark algorithm for Category 2 is embedded in there, and so that's another fantastic tool that supports, decreasing that time and responding to Category 2 tracing. So I know you guys are coming up on reassessment around fetal assessment monitoring, so that'd be another great measure to see what's happening with Category 2 with your team going forward.
Laura, how long does it take to get the data from GNOSIS?
Oh yeah, great question. It's automatic. And again, I think Lorraine has a great model. If you recall in the very beginning, she said they give their team 30 days to complete their assessments and, over time their learning paths. But as soon as a team or an individual completes their assessment, you hit submit, and it's automatically generating reporting. An individual receives their own dashboard that tells them how they did compared to their peers nationally in any one of the major 4 assessments that we have today in the 4 high-risk OB areas. And then as soon as we also advise that leaders launch the programs in a very programmatic way. So number one, you're doing an obstetric hemorrhage initiative as an example, and all the team, physicians, nurses, midwives, are taking that assessment during the same defined time period. So then leadership has access to the data. So you're getting that snapshot in time. Where's the variation? Where is the risk? And what in the content areas do we need to focus on? Is it quantification of blood loss? Is it anatomy and physiology? Is it, communication and teamwork or blood products? And you're getting that type of specific clinical feedback in your data.
Another question, Laura. Generally, how long does it take if you were to have your team complete all 4 modules in GNOSIS for OB?
This program, and Lorraine, you spoke to it as well, this is an ongoing program. This is not, we say, not a one and done. It's not traditional education where you read a paragraph, take a post-test, and check the box. You actually do your assessment, you do your learning plan, and, and let's say you do that in quarter 1 of year 1, and then 18 or 24 months after that, you're reassessing the same content, because your brain capacity and your information degrades over time, and the team changes. You have nurse turnover, you have residents coming on staff, etc. So it's important to constantly be giving that clinical team the national evidence, which is how it's delivered. And so, for example, electronic fetal monitoring is it's about a 1.5 1 hour and 45-minute assessment, and then maybe a 2.5 hour learning path. It's the most robust course. Obstetric hemorrhage, as an example, is a 1.5 or a 1 hour assessment and a 1.5 to 2 hour learning path. And shoulder dystocia, HDP is very similar to that. Shoulder dystocia is a little bit smaller. So there's a cadence to learning, there's a sequence to learning, and you deploy these programs, either 1 or 2 in the same year, and then you stagger them with the other programs, and then you repeat in the out years. And then you use the data and the feedback to drive other elements of education, just like Lorraine was talking about: simulation and team training, protocol evaluation, protocol development, etc. Lorraine, anything you would add to any of that content, any of those questions, how it works for you?
I don't think there is a time. I mean, the assessment itself doesn't take long, but the learning path is, I mean, everybody's different. You know, for some, we have to say, you know, you have 90 days. Some will turn around and do it in 2. It's like, I think your point is ongoing. And some people just learn faster than others, but you know, we do provide time for them. Where our organization is, you know, is not yet to where you can do it at home. We'd like to get there. It's just the whole pay component and all of those things. But it's works great for us, but we don't put time limitations on it. I mean, there is, you can't have 2 years to do it, obviously, but I think that's the nice part of it. They can come and go and pick up where they left off every time they log in and out.
Oh, nice. Okay, Tom, I think we're about 4 minutes to the hour. Any more questions?
Actually, there were 3 questions, and we can answer them all at once. Someone wanted the GNOSIS scatter plot chart explained. That's one question. And then, how do you use GNOSIS data to inform the AWHONN instruction? And then the third one is, did Winnie Palmer, when you looked at someone in the lower quadrant, what did you do as part of your program for those learners? So,
and Tom, while we're thinking about it, we're gonna answer that. Can you go back to that slide?
The last part about what do you do with someone in the lower quadrant? Well, remember, it's just an assessment, so they have to do their learning path. So they have to, for anybody that's, you know, up in the upper part, we don't necessarily make them go back. We do reassess people that are in the lowest quartile. We don't, we had that. I think where I understand the question is coming from, what do you do? Do you let them continue to practice? But, you know, many of these are new nurses coming in. Many of these are residents that haven't even hit the floor yet. So we do, if they're in the lower quartile, then we put them through the learning path and we do reassess them. And the goal is to get them above where they need to be. We have not had anybody yet that continued to stay in the lower quartile after their assessment, their learning path, the simulation. We have had to have some of them have, we do send people also to the traditional AWHONN fetal monitoring course. We do require that. Everybody has to do that once. You know, as somewhere in their career, they've had to have the AWHONN sit down, fetal monitoring course, and then this is what they do from, I have nurses that are 20 years out. They don't go back and take that AWHONN here. So if somebody continues to stay in the lower quartile, we would then put them into classroom learning. So it depends on your people, but we have yet to have somebody assess in the lower quartile, do their learning path, do the simulation, and not improve.
Yeah, and I think that's a very consistent answer with how I would advise and counsel other clinical leaders on how to look at this data. Specifically what you're talking about really, again, is back to the blended model of education. If you have clinicians in that upper right quadrant, keep in mind they're demonstrating proficiency in this particular course content. So it's not necessary to continue to, embed them in some of the traditional didactic courses. But for those individuals that are demonstrating, a lack of proficiency in some areas of the content, that's exactly an appropriate time to bring in the didactic instructor-led model. In this case, for nursing, it could be the AWHONN intermediate course or, the advanced course, or some just one-off coaching. And so you have to kind of assess each of one of those individuals. But again, keep in mind, it's typically a fairly small percentage of the entire team, but it's a great view to say, okay, now I have a snapshot of where my team is in time. And keep in mind, we're measuring 2 primary variables in our program. We measure on the X and Y axis judgment and knowledge. And so that's a very unique component. They're being asked about clinical situations in a changing patient situation, and can the clinician apply what they've learned, through their program. So those are some of the facets and the unique components of GNOSIS. So I think we're right at the hour, Tom. If there are other questions, I would just say please send, write them in, email APS. We'll follow up with you directly. Lorraine, I want to take this time to tell you thank you so much. This was we've all learned a lot. Congratulations on all your success. We're looking forward to working with you in the Mothers and Babies program, and we hope that you're all going to have a lot of success in your perinatal safety initiatives going forward.